Being scared of surgeries is perfectly normal. There is nothing to be shy or embarrassed about. Behind the knee pain or a joint pain, a lifestyle has a major role in that.
At what point of time surgery is required?
Robot is now generally considered and accepted as a safe tool to assist in surgeries. A lot of non-surgical options are available, like physiotherapy, physical medicine, some external heat application, injections into the joint if the situation warrants. It's very rare to see that a patient would be, unhappy about the pain after surgery. It should not be, and it is not most of the times.
Knee pain. We usually dismiss it by saying that, okay, it might be just the age of mine or vitamin deficiency, or it will get better over the time. But usually that doesn't happen. Gradually that pain grows and you're not able to move. The mobility is decreased, you're not able to climb stairs or even sit cross-legged. So today, to talk about all the pain that hurts you, we have an expert, Dr. Thirumalesh K. Reddy. He specializes in robotic total knee replacement. He's an orthopedic surgeon, very big surgeon in India, and he's been curing a lot of people. And right now also he's just come out from an operation theater, totally visible. Welcome, sir. Thank you so much for your time, first of all.
Thank you for having me.
Let's start something away from the operation theater, sir. Tell about yourself, your journey, where you come from, where you were born, where this medical surgery or medical came in your dream that you want to go with this.
I was the first doctor in my family, so a lot of family members were looking forward to have a doctor in the family, so I happened to be the first one. And I was brought up in Bangalore, so my basic training, education, my medical school, everything in and around Bangalore. I did my MS orthopedic training also in and around Bangalore. After my MS orthopedics, I trained with a very renowned surgeon at the time in Bangalore. A couple of years later, I went abroad to the United Kingdom to have expert training on joint replacements. I was there for about 5 years, and then post that came back to Bangalore, and I've been in Bangalore.
So you're one of the rarest doctors who comes back to India and serves people over here.
I wouldn't take that credit, but one of the doctors who came back.
No, because clearly in India we have less doctor in terms of 100 people on the geography. So we have actually less number of doctors in India. But you coming back to India and serving people in India, there was any reason behind it?
I always wanted to come back, so I had no intentions to settle down away from home. So family reasons, social reasons, and professional reasons too. So it was always the plan to come back to India. So.
And straight away into orthopedic. So you are one of the best known doctors in India about arthritis, orthopedic knee pain. What got you into skeletons? I mean, it's on your cap also. It's very evident. It's a very unique cap. You're wearing operation cap, right?
I have an anecdote to that. So during my medical school, when I was in my second year MBBS, so I happened to have a fracture to myself.
Right.
It was a fairly major fracture. So I spent nearly 4.5 months attending to the fracture, and that was my right hand, the dominant hand. So
you were in a fight?
Well, fortunately, no. So I had a fall, and then that was out of an injury.
Right.
So for that fracture, I visited Dr. Srinivasan, who is my mentor, my guru, and he probably is the best surgeon I can think of amongst my seniors. So he was treating me, and looking at him and his team and his kind of setup and his approach to an orthopedic patient. So that triggered and initiated my interest, and I was lucky enough to join him after my master's, and I was really happy with the training I had.
You don't look very old, but nearly how many years now it's been operating people?
Well, I think that's where the cap helps so to mask my age. So I've got 25 years post my MS experience. So
25,000 patients nearly?
I wouldn't say
than
so.
That?
Much less than that, but I think the joint replacements themselves, the ones which I have done as a consultant, I think around 6,500. This including the ones which I've done in the UK.
All right. And keeping still to the older part of your story, like all your doctor education, medical education got over, and you chose the place Bangalore, your hometown. You are in love with your hometown, isn't it? Bangalore.
Absolutely. So my parents' intent was for me to start my practice in my native, which is my father's native. Mm-hmm. So it's a small town, a very small town. So
where exactly you in?
This is a place called Bagepalli.
Acha.
So this is about 100 kilometers from here, and it's border to Andhra and Karnataka along the airport. So that was the desire, and they really wanted me to. But then I felt after all this training and all that, so I shouldn't, limit myself to a smaller place, and I wouldn't have the opportunity to, practice what I wanted to and what I trained for. So it was. So
first of all,
is nothing.
First of all, hats off to you for coming out of small city, small town, and going way up to UK and studying your medical, and now you're 25 years of experience. Hats off to that, sir. You're an inspiration yourself.
Thank you, and I credit all this to my teachers, my mentors played a major role in that. So it's a long path. Definitely. And I can't take credit all by myself.
Definitely.
I was mentored.
So today, sir, we are talking about pain, whether it is knee pain. We come across a lot of people, whether old people. In your house also, there are people who might be complaining about pain. I mean, you get daily people who complain about the pain. What are the common reasons behind such pains? In India especially, what is the common reason?
See, the pain in general will be a very vast topic. So if you just limit our talk to joint pains, particularly knee pain, which is one of the most commonest one, in fact. So it can happen across all age groups. So in a younger person, it could just be a simple physical activity, a strain, or a minor twist, injury, which are all completely reversible. And starting from that, on one end of the spectrum, it could range to the extreme where arthritis of a significant extent where their activities will be significantly limited. So it could vary from that. So the intervening reasons could be a meniscal injury or a ligament damage or even infection in certain situations, which can start off as just a pain in the joint. Which only when we start evaluating, we will get to know the actual cause. So that is one reason. And inflammatory causes is, again, this is something which is a disease, not just lifestyle or an activity or an age-related thing. So like rheumatoid arthritis, psoriatic arthritis, gout. So these problems also can manifest as a joint pain. Usually a knee is one of the common thing amongst all these causes.
So can I take it as that, these terms are quite heavy. So if we want to simplify and tell people that the reason for you having this pain is because maybe your food is not good. Maybe you're overweight. Maybe your lifestyle is not okay. These can be the reasons, basic reasons also.
Totally right. So irrespective of what exact cause is behind the knee pain or a joint pain, a lifestyle has a major role in that.
Right.
Say to manifest and to progress and to resolve, in all aspects, the lifestyle will have a major role. To break that down, food, as you mentioned, so we should have a healthy diet. Healthy physical activities, good exercises, and also to avoid injuries to the knee. So definitely lifestyle has a major role, especially diet, because an unhealthy diet, it could be undernourishment or overnourishment, which will be a more important aspect here. So weight.
It's overnourishment, I guess.
Weight.
Diabetes and
true.
Lot of.
So overweight will also speed up the process of wear and tear.
Right.
And once it does happen, the impact of overweight on an existing arthritis will be more. The extent of pain will be more. The limitations will be more pronounced. So certainly has a major role. Likewise, in remedial measures also, weight of a person has a significant role too. Generally, people put on weight gradually over a long period of time, and then it may not be something which draws their attention in a short span of time. But then it does have a direct impact on the weight-bearing joints. Knee joint is one of them.
Right.
So as much as overweight does not trigger arthritis, but it does have a significant role in the time frame that it affects and the progression, the rate at which it progresses, and most of all, it's directly linked to the extent of pain and limitation a person has. Because you just imagine a person who is lightweight has a certain extent of arthritis, of course, apart from their pain tolerance and other factors. So the impact on the worn out cartilage or the wearing out cartilage will be more if the person is overweight.
Right.
So the progression also will be a little faster, relatively faster. And the limitation, which is basically what will usually draw their attention, has a role. And they definitely have the overweight also has an impact on the remedial measures too.
Simple science that the more the weight is, the gravity is more on the knee.
Mechanic, we can call that a straight mechanical
Right.
factor.
Usually in India, what happens is whenever, I have suffered pain. I go to gym, but if I have a pain in my back, I usually avoid that. Saying that, it might be just because of the exercise, so it will get better over the time. And I should avoid the doctor because, of course, I'm scared of doctors. I'm scared of medicine. I'm scared of the routines. So what do you suggest when it comes to what point it comes wherein you should actually go and see the doctor? The pain, it goes worse, or you should just be going to the doctor if you are in pain?
That's a very, very valid question. So, just as you started saying that when you go to gym and then you notice this pain because of a certain exercise or an activity, you avoid doing that.
Right.
So that's how important and how logical it is in most of the situations. We discussed about the causes of pain earlier today. So based on that, it's quite obvious and logical for a person to understand the nature of their pain, the reason why they have pain. So most of the times, as we discussed earlier, if it is something which they already know why the pain has happened, like a physical activity which is put strain or a minor twist or an injury, most importantly, something which they are able to continue with their day-to-day activities, doesn't have to, limit anything or avoid doing anything because of the intensity of pain. Those are things which they can ignore, and just as you rightly said, avoid doing that, or just give a little rest, or even sometimes people may just take some simple pain medicines, commonly known pain medicines. And despite all of these things, if they feel that the pain is drawing their attention more often or more intense and limiting any of their activities or stopping them from doing what they should otherwise be able to do, that is a situation when it's probably better to see a doctor without any further delay. On the other hand,
as the ease of mobility decreases, we should,
if they feel in a reasonable time, say a day, 2 days, 3 days, if they start feeling better, that should be good enough to not having to see a doctor. On the other hand, if the cause of the pain is fairly significant, like say they had a major injury or a major fall, or things that starts off with a very severe extent of pain, that is something which usually one should not, ignore or delay in seeking help. It could turn out to be nothing major, but however, these situations, I think it's best to see a doctor at the earliest.
So Dr. Reddy, I said that I'm scared of doctors, and many of them are, truly and honestly, because many people think that going to a doctor will straight away tell you for surgery. And surgeries are scary, of course, when you are an expert to it, but at what point of time surgery is required?
Well, I completely agree with what you just said, and it's true most of the times. I can tell you that it's probably true even if I take me into consideration. I'm a surgeon. It's routine for me to operate, not be scared of surgeries. I can't be. But if I have to undergo a surgery myself, I can't say that I wouldn't be scared. I might be scared for some reasons. But for a person who is not a doctor and who is having pain and it brings them to a doctor, naturally they would feel that there should be ways without a surgery to address their issues. Being scared of surgeries is perfectly normal. There is nothing to be shy or embarrassed about, because I can see myself in that situation too when I need to. So when a person comes to a doctor, naturally they will have this apprehension that whether the surgery will be advised to them or not. But then basically it all depends on what the problem is. So most of the times, at least in this time, at this era, I think people would know what is major and what is not so major. So when we come down to arthritis, that's when usually the fear comes. I don't want surgery, because normally nobody would want a surgery as an option. Forget even being the first option. So with that in mind, when they see a doctor, a surgery would only be recommended when they need it. So surgery is not the only option for managing a patient's concerns. There are other options too. Again, it depends on the situation, as in the cause of the pain. And when we speak about arthritis, which is our main focus today, So the stage of arthritis, and depending on earlier stages, simple lifestyle measures. We spoke about weight, we spoke about lifestyle, we spoke about avoiding injuries. So these ones. So if it warrants, a lot of non-surgical options are available. So even as the arthritis progresses, say over a many years of time, the options of treatment will expand to situations like physiotherapy, physical medicine, some external heat application, and injections into the joint if the situation warrants based on fulfillment of certain criteria, and weight reduction, which is a long-term process, but then that is an option too.
So the pain, unless it becomes chronic, so you don't need a surgery, is it?
Chronic is one reason, and also it should be in a situation where other options apart from surgery would not be beneficial.
Right.
That is an important factor too. See, these surgeries, especially a joint replacement, is not something which is done as a preemptive thing or a preventive thing.
Right.
Oh, I'm going to need a knee replacement anytime in future. Why not get it done now? It's certainly not one of those, and it should not be thought of also.
Right.
So as we move on, so surgery will be necessary in an advanced stage of arthritis at some point. So what is that point? From a patient's point of view. So the pain would be quite severe, continuous, limiting their routine activities. See, a person may want to do quite strenuous activities which may or may not be, matching the extent of arthritis or even their age to some extent. So keeping that in mind, if they have some limitation in their day-to-day routine activities, or they're unable to perform certain basic routine activities, so that is the stage usually when a person would have to see a doctor. And then at that point onwards, moving forwards, we do some tests, examine them, x-rays, and if the x-ray shows that the arthritis is of a severe nature, an advanced stage, if you can put it in simpler words. So when all these factors match and are there, that is when a surgery would be necessary and helpful to the patient.
Now, Dr. Reddy, you specialize in this activity called a robotic total knee replacement. I am listening to this for the very first time, being honest, but what is it? Please, if I listen to it, I imagine that a robot is doing the treatment or surgery. So are you doing it or the robot is doing it?
Well, it's a yes and no. So to start off, traditionally a knee replacement was done using instruments and gadgets, and we call that jigs and things, cutting blocks, which basically allows us to assess how much of correction a person needs based on the deformities or the arthritis they have. And as we start the surgery with experience and with what we've seen on that particular person's knee, we make decisions, plans, and the corrections, and prepare the joint to have an implant placed. So that's how traditionally a knee replacement has been done, and this has been going on for quite many decades. Now, robotic assisted joint replacement is something not very new, to be honest, in fact. So this was started off in the early 90s.
Okay.
In the late 90s, it was approved by the US FDA. But then the popularity of a joint replacement assisted by a robotic system probably last few years, I would say 5-6 years. Okay. And certainly in India, I would say about 5-6 years on a common scale. Exclusive trials and a few surgeries were always happening.
So as you say, robotic assisted. So it is actually your assistant. A robot is your assistant.
Yeah, the perception is like that, isn't it? Like in the movies and things like that. When we hear a word robo, yeah, it does come in like a human form, right, a machine in a human form. But in reality, it is not so in a joint replacement. So it has a few components. Okay. It has a main console, it has a planner, and it has a robotic arm. Right. So these basically, it works on the principle of a computer on the robo. Okay. So what we do is we prepare the surgery before we actually start that.
Okay.
We will need some CT scans of the person's knee. Right. We create a 3-dimensional image of that and upload it to the computer on the robo. Right. And which is part of the robo. Right. So it just looks like a monitor, a laptop. And we start doing all the calculations which we traditionally do once we start the surgery. Before even we do that, based on this 3D images of the patient's knee, and calculate and decide what size of implant or how much correction or where exactly to place and in what direction the implant has to be placed. And once we are assured that this is the best possible way, option, that's when we start the surgery, right, with the pre-planned thing. So once we start the surgery, there's a little more to just the robo performing that. So we place something called as trackers onto the person's bones around the knee, and this is how we communicate between the computer, the robo, and the person's knee. So we double check this with whatever we have planned earlier on by mapping a person's knee.
Right.
So it's called registration, and then the robo gets a real-time picture of the person's knee once we have opened it up. So this again, we go through a few routine steps to make sure that how much we should correct in terms of deformity, be it the direction, angle, things like that. And both the pre-plan and this has to match.
Right.
So once we do that, then the robotic arm, once we accept the plan and we say yes, that's when the robotic arm will do the cuts part.
Okay.
So it's not entirely a robot doing it.
You're making it function to do it.
Yeah, see, as much as the robot does an important part of a knee replacement, the surgeon's role is definitely there. That's why it's called a robot assisted.
Basically, we are incorporating technology into your work as well
Yes.
to help you out. Like
Very true.
nowadays, we have CRISPR technology to find out the DNA sequences. So similarly, this technology is helping
true.
you to
Very true.
do the surgery.
It only helps us to plan better. It incorporates technology into our surgeries.
If you can
surgical
tell us
field
that
too.
how robotic total knee replacement or robotic assistant surgery is better than any normal surgery.
It's a difficult question to say as a one-sided thing. Yes, on principle, yes, it is certainly better than a traditional surgery in principle, because the accuracy is what is always spoken about, and that's what patients also expect. That doesn't mean that a surgery done without an assist of a robo is less accurate. So the difference in robotic surgery is we plan everything up front before even we start the surgery, and we know the sizing, we know the extent of soft tissue releases that we have to do. All that is known before we start surgery, and it's planned, and the execution part will definitely be as how it's been programmed to. So that can be matched by a non-robotic thing, but that again depends on surgeon's experience and the tools that they use. So I wouldn't say robot is very clearly
But that
the best way forward.
that brings up a lot of misconceptions among people about the robot doing the operations, which is not real. The doctor itself is operating, like you said, but these misconceptions are there. Like you must have come across a lot of them.
True. So there are different types of assist from different robo also. So there are certain systems where the surgeon still has to hold the tool which actually does the cuts. But it will be guided by a pre-program where you only will be able to cut in the pre-programmed areas. Anything you deviate even intentionally, it will just switch off.
Okay.
So there's some systems like that.
A few more examples like this,
So there are another system where you program it completely, and then the surgeon's hands are free for those few minutes, where the robotic arm does the entire cutting part. So the surgeon physically doesn't have to do anything during that process. So there's things like that. So it is different, but certainly the robot doesn't decide on anything. It doesn't change anything mid-course. It can switch off when for some reason, say there's a movement by the patient or there's a movement mechanically. If something is away from its programmed area of where it should do the surgery, it will switch off. Those safety measures are always. Otherwise, it could be disaster. Right. So barring that.
So you're not relying 100% on the robot to do everything, but you are the boss over there in the theater.
Certainly right.
There might be misconceptions about this kind of operation wherein a robot is involved. I also have a silly question about it, that a robot can go rogue and harm the patient also.
That's a very, very interesting question. And to be honest, in theory, yes. The simple reason being, anything can go wrong. Anyone can go wrong. Anyone can make mistakes, whether they're intentional, unintentional, accidental, technical, whatever the reason may be, things can go wrong. So, just as much as a human can go wrong, an object or a computer or a robot made by human can go wrong in principle. But because we use this on a person, on a patient, so a lot of testing and away from a person would be done, and then when all the safety measures have been met with, then they would test this on cadavers, and only when it's completely accepted beyond doubt, not even reasonable doubt,
Right.
then is when it's used on a human.
So not so soon, it's not going rogue.
And as I said, it can still go wrong. As I said, machines can go wrong. So that is where there are backup measures,
Right.
measures to switch off automatically. And there is an option for a person outside of the operating team to to switch off the machine in case they even sense something is not right. Okay. So there are multiple levels of safety checkpoints which are there to prevent in case something does seem to go wrong, which usually does not. And naturally, they'll all have, regular maintenance and the pre-run, just to ensure that everything is functioning even before the start of surgery. Everything will be pre-run once the plan is done. And that's the last point. I mean, that's one of the point where we can double check that technically there's nothing wrong with the system.
So this robotic assist during the operation, it quite helps you. Very much has a lot of good things about it, and technologically advanced, gives you accuracy. But I'm sure there must be some limitations of it. Can you talk about
True,
that?
very true. So the most important thing which comes off at this point where robot is now generally considered and accepted as a safe tool to assist in surgeries. The limiting factors, one of the important thing is the cost, because it involves a lot of consumables which are a one-time use, which will add to the already existing cost of a knee replacement. And it does take a little longer than a conventional surgery, because there are a few steps which are mandatory to establish communication between the patient and the robo, the computer. That takes some time. It is initially a bit longer, but then as a surgeon gets more and more experience, it does get down to shorter time, but it does add on to a few more minutes. That's another one. 3, expertise. Not everybody would have the experience or the exposure to perform a safe robotic knee surgery. And availability, limitations in availability. It's just still a field where it's just evolving in terms of availability, the spectrum of availability. So that could be a limitation. And from a technical point, there are certain situations where it may not be the best thing to use a robot assist, especially patients who are extremely overweight. Just by the sheer shape of the knee, it may not be possible to use a robo in the way we should, because the robotic arm moves in various different angles, directions, as what is required. So the anatomy of the person's leg may not be giving access to the robotic arm, the cutting part. There are means to address that, but it could
I have
be.
an example for this. My tooth root canal was being done, and it was so difficult to dig in that she had to do it manually, not with the robot.
Exactly. So that's something which can have a limit, which is a limitation. And 2, extremely severe deformities. What I mean is people who have been ignoring or delayed the time that they seek intervention. Another important aspect where there is limitation in using a robotic assistance is when a human judgment is necessary. Right. This is during the surgery, and which is not beyond the scope of a standard task. A robo is basically programmed to perform a standard task. So the programming involves a lot of technical things, but when once it's programmed and then given a command to go, it does exactly what it is programmed to. In complex situations, extreme deformities, especially where people have been ignoring their need for surgical intervention for a very long time, this is where a human level judgment would be necessary. And cannot be programmed as a standard task. That would be a good reason to stick to a traditional knee replacement rather than a robo, because a robo is programmed to perform a standard task.
Correct.
So situations can be there where a human level judgment may be necessary. So, but not very common. But yes, there are limitations.
So I can say also one more limitation can be that it is a costly treatment.
Yes, certainly. So it is supposed to be less painful in relation.
Right.
Probably not to the pocket.
So someone who wants less pain, go through the surgery smooth, should go for the robotic.
That's in principle again. Right. So see, pain is part of a surgery.
Of course.
So as a knee replacement, because it involves cutting open a joint and then placing artificial implants inside, which will involve some tissue dissection, which is relatively less when a robot is assisting. But nevertheless, after surgery, there will be pain. It will be wrong to say that a robotic assisted surgery will be very soothing, comfortable to patient just because it's robotic. No. It could be less painful because there's theoretically less dissection that is necessary, and there will be some pain because when an operated knee goes through some exercises which are part of a recovery program, there will be some discomfort or even mild pain, which is usually controlled well with pain medicines and ice therapy and exercises, which gets better by the time. So the pain is not something which will be absent following a robotic knee replacement. And to be very honest, a person will not know whether it's less pain or more pain. So unless they have one knee which is done without a robot assist and the other knee with a robot assist, they can compare which one is less.
Okay.
Otherwise, in principle, it is expected to be a little less painful. But to the person, which usually is either a conventional or a robotic, either way. So they
just
may not
a
be able
little
to
extra cost on the pocket for the robotic one, but yeah, it's more reliable and accurate also. I mean, you are an orthopedic specialist and you can do either of the ways. You can go either of the ways. But depends again on the patient. What
this is purely because it involves consumables and especially the ones which are only a one-time use. And that's not something which will be used in a traditional surgery. So that will add on to the cost.
So doctor, usually we get these complaints of knee problem or joint pains from the elderly people. So is it bound to only the age group or a certain age group, or pain can be with anyone and any point of time injury can give you a pain, a long-lasting pain?
Generally speaking, pain can be at any age group depending on the background. But then when we speak of an arthritis of an advanced stage and a person who may need a surgery to that, usually it is expected to be someone in the retired age group, say 60. It used to be a 60 as a cutoff number earlier on, but then it's more functional now. So generally, it's people of a little elderly age group. Now that is one of the common reason why people fear that surgery is not the best way forward for them, purely because of their age. They feel that they may not be able to endure the surgery, the post-surgery recovery time, especially from a pain point of view. Will they be able to tolerate, and will that be okay? So that's one of the other factors for fear, apart from the doctor himself.
Right.
So to be honest, I think in this era, with all the advanced techniques and available options with pain management, especially after a standard surgery like a knee replacement. It's a well-established surgery with definitive protocols about the surgery, post-op pain relief, physiotherapy, all that. So I can summarize in a simple sentence. There's no need for the patient to fear pain, because as much as I said earlier, there will be some pain, but I don't see a reason why they should regret that they had a surgery at all. it's very rare to see that a patient would be, unhappy about the pain after surgery. It should not be, and it is not most of the times. Exceptions are always there.
Some of them are
Also
there.
depends on patient's pain tolerance too,
Exactly.
which could be one of the reason why they would come and
Now, some of them are so rare that they don't want their surgery because they're like, okay, most of the elderly people say that any which way I'm going to die. So how does the surgery matter to me?
yeah, so that's another context too, because they all feel that everybody who have knee pain, a problem with their knee, a bit of bowing, that comes with age as part of life. Everyone. So I have too. So why should they think that it need not be addressed? They'll endure with the pain that they have. They'll limit their activities to a certain extent, and they get along. Plus the added factor of fear of surgery, fear of hospital, fear of doctor, fear of a potential reason for them to be bedridden after surgery. Someone should be there to look after them. So, which all of them are not true, because they will be up and about on their feet within a few hours after surgery, so 8-10 hours. So practically at least that evening or the next morning, they may need an assistance for a couple of weeks to help them balance. But then I've seen a majority, almost all patients, happy after the surgery, and as much as they have to endure the physiotherapy, time bound, it takes 6 weeks, 8 weeks for them to start feeling the benefit of surgery from their point of view. We can always assess saying that yes, compared to last week, you're better off today, this week, and the next week is going to be better. But then for the patient to feel that yes, they have benefited from a surgery, it may take 6 to 8 weeks. Simple reason being, the muscle strengthening is an important aspect of pain relief, and their ease of moving around, ambulating, performing simple tasks, and for that, exercises is the only
I
way
was coming to
forward.
that, like post surgery, the treatment, the physiotherapy that happens, how important is that and how most effective it is for the surgery after the surgery?
Apart from the fact that the patient has to agree and decide on having the surgery done, so leaving that aspect, there are two very important things for the success of any surgery, including especially a knee replacement. The surgery needs to be done in the correct way, in technically correct way. That's the surgeon's responsibility. Equally important is the exercises after the surgery. Physiotherapy, a more popular word, but that doesn't mean that they have to attend a therapy session in person, either outside or at their home. Simple exercises will be taught. The therapist will help them learn, do while they are in the hospital, and sometimes they may even visit them at home. But it's all up to the patient to perform those exercises themselves. You mentioned gym earlier, so I can use a metaphor there. You go to gym, you have to exercise yourself, right? So you can't engage a trainer and then sit back, drink protein shakes,
You're
and
building
then
your own strength, not someone
yeah.
else's
So
strength.
simple. So in a similar way, the patient has to exercise their leg muscles, which will take time to show positive result. During this time, they may not see the full benefit of surgery. So that's where it takes a little longer time, 6-8 months. It's a routine thing. And they'll always will be happier as the time passes with the surgery, after the surgery.
So, Dr. Reddy, I'm totally confident about the surgery. Now, if someone from my family wants to get a surgery done, a total knee replacement, robotic knee replacement, he or she, will he get a total brand new knee or like totally 100% working knee, or it is fine, charm chal jayega types?
Very, very important question, especially from a patient's perspective. So, yes, to some extent, I could say that it's a brand new knee. The patient would get a brand new knee from a technical point of view. So, how much would it translate to functionally, benefit them if they, expect that they would want to perform activities when they were able to do so in their much younger age, say in their 30s or 20s or the 40s. That may not be the reason why a joint replacement is done. So, basically, these surgeries were primarily designed for people of retired age group.
Okay.
So, for that lifestyle, it should be as good as a new joint. It should permit them to be independent. It should permit them to be taking a good walk. They should be permitting them to drive. They should permit to move around,
Climb stairs.
Climb stairs. Climbing stairs is with a little effort. It requires a little more
Then you need a
effort
little
because the
support
muscle strength, things like that. So based on that, the body weight comes into picture there. It should permit, but then it does not permit a person to do all the activities of their younger life, like say squatting on the floor, sitting cross-legged on the floor. Most of the times it permits a person to sit cross-legged, but then it also has a negative impact on the outcome of the surgery.
Okay.
An important thing what a patient would always look forward to is it should last their lifetime.
Right.
So in principle, yes, it would, provided it's looked after the way it should. You do things which puts tremendous pressure on the implant. That also could fail. That could wear out. Just as a natural knee can wear, even a man-made joint can also wear. So if they adhere to some simple do's and don'ts, it usually should last most of the times, even 20 years, I would say. Again, it depends on certain variables. So yes, they do get a brand new joint on principle, but functionally, yes, it will have its own.
At least they're getting basic mobility and
Yes,
that's more than
they
enough,
should
I guess.
have a pain-free situation to do their personal routine activities. That's the whole
After
purpose
retired
of.
age, they don't need so much of functionality.
The only
of
challenge comes where, because we see more often now in the last few years, younger patients are requiring to undergo a knee replacement.
Okay.
Now that's where, it
Please
becomes
give
a
me an
little.
example of someone who was doing it below 30, 35.
See, when it comes to a disease background, like say rheumatoid arthritis, people who have these problems, they usually end up having a requirement for a knee replacement at a much younger age, say sometimes even in their late 30s, early 40s. That's because of the damage to the cartilage from the disease process itself. So excluding those people, even younger patients without any of these backgrounds, if they get injury, say a significant fracture involving the joint or some major ligament injury or a meniscus, which is a cushion in the knee, if they have some significant injuries to that, which if they are not addressed to at the right time, so that can cause arthritis at a much younger age than otherwise. So eventually at some point, they would have a stage of arthritis at which point a knee replacement will be an option. If picked up at an earlier stage, there are other options too, apart from a knee replacement. But then I'm trying to focus on a situation where it leads to an advanced stage of arthritis. So there, a younger person, on one end, there's a requirement because they are young.
Right.
They have to perform more activities than what we can expect of from a retired person. So one is a requirement. Two, whether it will last, the outcome would it last as compared to a person who undergoes in their older age group. So that challenge will always remain.
So better be careful, not lose your knee at the younger age, and be careful with your lifestyle.
That's where the lifestyle and avoid getting injured. And if you do get accidentally injured or any other means where you couldn't avoid, so seeking treatment at that time can avoid getting into a situation where a joint replacement may be a last option.
Since 20, 25 years, you have been doing God's work, curing people and helping people through surgeries, giving them back their legs. Literally, you are giving them a life to move on again and be mobile again. Any example for us we have there wherein you could come across a patient that is, he or she is very much scared, terrified with a surgery, or how do you console them? What do you tell them?
See, as much as we can, explain things just as we have discussed during this last many minutes, it is sometimes possible that the patient may still not be convinced.
Correct.
So this is one surgery where I strongly believe we should not impose either from the surgeon or even from the family. See, there are situations when the family members clearly understand the benefits and the potential limitations or even risks in certain situations to undergo a knee replacement, but then they still agree that the knee replacement would help them. But the patient may not be prepared to accept it. So there could be situations like that. And honestly, I don't see how we can address that. Though sometimes in a similar situation, people may not want to have both the knees done during the same admission. So for the exact reason of fear, they would want to, want one leg operated on and then wait for a few months and then see how it translates to benefit to them. And then if they're convinced, they would consider to have the other knee done. So that's not a very uncommon situation. And to be fair, I think that's
Also,
that should
I
be
would like
accepted.
to ask the final thing. How would you convince them not to come to you by taking care of themselves?
Definitely, that's an important part of a surgeon's or a doctor's role. Honestly, see, surgery is only a last resort option.
Exactly.
Only when the arthritis reaches of a stage where there are no other options available, that's when a replacement is considered and to be considered, honestly. So that forms only a small portion of patients. So if you look at the number of patients visiting you in your clinic, outpatients, things like that.
So basically, I'm trying to ask the doctor, if you are scared of a doctor, no worries. I'm sure you might not need a surgery at a point of time in your life. But what should you do so that you don't get into that situation? I want to ask the doctor about that.
The number of patients who would need a knee replacement are not more than the number of patients who would not need a knee replacement, considering the situation of arthritis, pain affecting them, limitations, things like that. So there are a lot of things a patient can do to avoid visiting a doctor, or even after having visited, to avoid a surgery. This could apply even to patients who are in an advanced stage of arthritis, who need a knee replacement, and still there are certain means and ways where they can still avoid a surgery, at least for that moment. How long? That's for time to tell, like say few months or a year, 2 years. So those will be, changing lifestyle. That's a major role. So you tend to do an activity which puts pressure on the knee beyond your threshold, it is bound to reflect and draw your attention in terms of pain. So you try to avoid or limit those activities and do the good things. Some simple strengthening exercises to the leg, a simple walk, avoiding certain postures like standing for a long time, sitting on the floor, cross-legged, things like that. A lot of people, especially women, they feel, another important point to bring up here is women, for some reason, are a little more commonly affected and then often require knee replacement more than men, at least in our country. So when we speak of a retired age group and people around that age who would need a surgery, in our country, a woman basically gets more busy around 55, 60 years of age, purely from grandchildren, things like that. So traditionally, that's how it goes. So we can't look at them as a retired person. In functionality, they would be required to do a lot more things or continue to do what they have been doing earlier on. So that's something which they should draw attention to. So if just because you are a requirement to stand for a long time, practice of sitting on the floor for domestic reasons, you continue to do that, your pain also continues and it actually worsens. So you avoid that or limit that or switch to something different where you put less pressure, so your pain comes down directly, as directly as that, which can buy you a lot of time avoiding surgery. So that's something which plays a big role, a lifestyle change, even in situations where a surgery may be indicated. So that's one good reason to avoid surgery.
So Dr. Reddy, we came up with a lot of insights and knowledge about the operations and what you do, when people should do it. Now I would like to ask you one certain question with only 3 points. How someone, he or she, should keep their knee best throughout their life? 3 things.
I'll break it down to 3 do's and 3 don'ts. So the do's would be a healthy diet, a healthy lifestyle, and exercises. The 3 don'ts would be overweight, injuries to the knee, and a sedentary lifestyle. These 3 things, I think, should keep a person going for as long as they can.
So doctor, I have certain few sentences over here. You have to tell me these are all myths or not, okay? Joint replacements are not for the elderly.
Not true.
It is common to have joint pain and does not need intervention.
True.
Okay, so it's common to have joint pain. The surgery would be very painful.
Not correct.
It can be painful.
It can be painful, but it can be dealt with so that the patient does not experience or have to worry about the pain factors. Any surgery involves cutting, so in principle, yes, it could be, but it will be dealt with, pain management techniques where it should not bother them or affect them in a major way.
Right. The next sentence is they may not be able to endure the pain.
Not correct.
They can. Fear of prolonged bed rest need to be taken care of.
No. So that's the whole principle of a knee replacement, to make a person independent, as much as it may take 6 to 8 weeks for them to fully be functional, but they wouldn't be bedridden. Mm-hmm. So the bedridden part will just be a few hours, that also until the anesthetic wears off.
Okay.
So that's incorrect.
Alternative medicine, Ayurveda, homeopathy can cure?
No, not allopathy also, including allopathy. It cannot cure arthritis. It can slow down, it can alter, it can, change the course of it in time frame, extent, symptoms by lifestyle changes, medications, physical therapy, but it cannot cure. Because basically part of aging, so we cannot
you need to have
overcome that
over the time.
Yes.
If it grows.
We cannot cure that. We cannot reverse the process of arthritis, nor can we halt it from progressing. But we can certainly alter the speed at which it moves forward. That can be done.
So another sentence is joint injections can restore cartilage.
Incorrect.
That's not true. Okay, I have one more question from my side, sir. I've heard that vegetable oils are good for bones or joints. Is it good? Is it true?
Not entirely true. See, a healthy diet, which also should take care of the nutrients required for a healthy cartilage, is necessary. I'm not an expert, but I don't think consuming vegetable oil would have a direct positive impact on the health of a cartilage. As I said, I'm not the expert. But
we have seen the babies getting massage on the very early when
that's external application. Yes, it would have the benefits of a massage or even a warm fermentation. It could be by an oil or it could be a simple water fermentation. So that external application certainly will have a positive impact. But in people who have an advanced stage of arthritis, so that benefit would be there for them too, but then it will only be momentary. It wouldn't have a long-lasting.
So there's no specific food or
food. Yes, food should be food. Unlike the common belief that calcium deficiency would cause arthritis, and taking supplements of calcium will get rid of their pain because of arthritis, that is incorrect. But calcium is necessary for a healthy skeleton. So that for the normal functioning, which has a direct, indirect impact on occurrence and progression of arthritis. So a sedentary person, that's where it would come into picture, or people who have calcium deficiencies. So for indirectly, their activity or lack of it can cause bones to become weak, muscles to become weak, which again indirectly affects progression of arthritis. So in certain ways, yes.
Overall, thank you so much, Dr. Reddy, for your time with us. And at the end, please give us some advice, small tips and tricks.
Thank you for having me too. And to conclude, there is nothing to be worried about having arthritis. Most of the times it's part of our life. And there's certainly reason to see a doctor when it is necessary, and to avoid getting into a situation where you may end up needing a surgery, or at least to prolong, lead a healthy lifestyle, healthy diet, avoid being overweight, and incorporate some simple exercises that you can endure as a regular basis.
Thank you so much. Thank you.
Thank you.